Welcome to the Guideline Summary by PACU. This is the diagnosis and treatment of adults with community-acquired pneumonia, released by the American Thoracic Society and Infectious Disease Society of America in 2019. The purpose is to provide updated evidence-based recommendations for the treatment and diagnosis of community-acquired pneumonia in adults. For diagnostic testing, the guideline makes several recommendations. Sputum gram stain and culture are not routinely recommended, except in severe CAP or risk factors for resistant pathogens. The yield is low and routine use have not shown to improve outcomes. Maybe consider if risk factors for MRSA or Pseudomonas, or in severe CAP needing endotracheal aspirate cultures. Blood cultures are also not recommended routinely, except in severe community-acquired pneumonia or risk factors for resistant pathogens. Contaminants may lead to false positives. Recommended in severe CAP, where delay in effective coverage has consequences. Also recommended if risk factors for MRSA and Pseudomonas. Legionella and pneumococcal urine antigen testing are not routinely recommended except in severe CAP or Legionella outbreaks. Evidence does not show clear benefits. Some studies show association with reduced mortality, so may be considered in severe CAP. Rapid influenza molecular testing is strongly recommended when influenza circulating to guide antiviral use. Reduce mortality risk based on observational studies. For determining the site of care, guidelines recommend using Pneumonia Severity Index score to guide outpatient versus inpatient care. Multiple studies show an increase in outpatient treatment safely. For hospitalized patients, using the IDSA ATS minor criteria to guide general ward versus ICU care. These criteria have good sensitivity and specificity for identifying patients needing ICU care. For outpatient, antibiotic recommendations include: for healthy patients without comorbidities, high-dose amoxicillin, doxycycline, or macrolide if pneumococcal resistance is low, based on studies showing efficacy including inpatient CAP. For patients with comorbidities, amoxicillin clavulanate plus macrolide or doxycycline for good coverage of drug-resistant strands, or monotherapy with respiratory fluoroquinolones. For inpatient, recommendations include: for non-severe CAP, beta-lactam plus macrolide provide synergistic coverage of typical and atypical pathogens. Monotherapy with a fluoroquinolone covers the major pathogens. For severe CAP, beta-lactam plus macrolide or beta-lactam plus respiratory fluoroquinolone is recommended based on observational data. No extra anaerobic coverage is routinely needed for aspiration pneumonia based on microbiological studies. May consider if lung abscess or empyema present. Cover empirically for MRSA or Pseudomonas only if local risk factors are present. Prior isolation of pathogen is the strongest risk factors. De-escalate therapy if cultures are negative. Other therapy recommendations: do not routinely use corticosteroids except in septic shock refractory to vasopressors and fluids. Studies do not show clear benefit. Use antivirals in influenza positive patients to reduce mortality risk based on observational data. Treat for a minimum 5 days if clinically improving. Can incorporate validated clinical stability criteria. The guidelines no longer recommend using healthcare-associated pneumonia classification to guide antibiotics. Instead, emphasizes determining local risk factors and epidemiology to guide the need for MRSA or Pseudomonas coverage. The guideline provided updated evidence-based recommendations for the diagnosis and treatment of CAP in adults. Key implications include avoiding antibiotic overuse by relying more on local microbiological data and clinical risk factors to select appropriate empiric therapy. For a comprehensive review of this guideline, click the link below, and for more pharmacotherapy insights, visit our website or follow our social media page.